How did you do? You just was adding that.
How did you do that? I pushed the button.
Yeah. Push the other part of the.
That comes on now, next speed.
Yeah.
And then just give it a 1, 2.
Okay, 1, 2.
Lovely.
It is. It's me. Good afternoon, everybody. Welcome to this rather hastily put together BRC seminar series from the rehab theme. I'm just going to run through, first of all, a little bit of housekeeping and a few BRC related issues, kind of little notices, and then I'm going to introduce the talk and also just give a brief bio. But before I start, I'm Sally Lamb. I'm one of the theme leads for the rehabilitation theme in the Exeter BRC. I also happen to be the director of the Exeter BRC as well for my sins. So my first job is both to welcome the people in the room and to let you know that there's coffee and cake outside. You can help yourself whenever you like. You can either have it now, in the middle, or later, whatever. Welcome a number of people online, and hopefully everybody online can hear us, but we've got quite a number of people attending online, so welcome also to those people. Fire exits are outside and down the stairs to the main entrance and into the quadrangle. We're not expecting a fire alarm, so if one goes off and it doesn't turn off, then we do need to leave, but I'll be in charge of that. I'm not a fire officer, but I can give it a whirl. Nearest toilets are just outside the seminar room, down the corridor on your left. And just so everybody knows, we're going to record the seminar, so please, if you're not happy to ask a question and be recorded, just don't ask any questions, but we are recording. A couple of reminders for the Biomedical Research Centre, please. It's absolutely vitally important for all of us who are touched by the BRC, and that's all people in our theme, all people who would like to apply to our competitions but not necessarily win out in them, to make sure that you acknowledge the BRC in your publications. It's really important for all of us. The better we do as a collective, the more likely we are to get funded in the future, the more opportunities we will have. So please can I encourage you to make sure that you do that. And this is the acknowledgement that needs to go on. If you've got any questions or queries about that, Sophie and Claire will be very happy to answer those, but just a reminder to you to make sure that you do that. Also a reminder that we've got some competitions coming up very soon, and I know people will be applying for these. We've got the Translational Fellowship competition, which closes on Friday, the 18th of October. That's this week. So please make sure that if you are doing an application, you get it finished up by Friday. We've got our BRC mid-career fellowships for clinically qualified folks, and that comes up on the 1st of November. So again, please don't forget that deadline. All of the information about how to apply is on the website. And again, Sophie and Claire will be very happy to have a chat with people who are wanting or thinking about applying. And finally, we've got our small research project grant call, which will launch early in the new year, so probably about January or February, and we'll get the details of that out fairly soon so people can kind of prepare themselves for that competition as well. So those are the various competitions that we've got coming up, and I'm just going to move now to talk a little bit about well, shall I give an introduction to your talk, or will you be able to just kind of go from standing point?
That's good.
Yeah, I'll let Clemens do that. So now I'm just going to introduce, first of all, Professor Clemens Becker, who has been a friend of mine for a very, very long time. So please be nice to him. He's a geriatrician and a clinical scientist. He's currently working in the University Clinic in Heidelberg, Germany. He's leading the unit Digital Medicine for older people, and he's working in an interdisciplinary team, mostly in developing and validating wearable technology and apps to address physical mobility. Until June 2024, he was the clinical lead of the Mobilise-D consortium, and he's very busy analysing and publishing lots of results from this largest global initiative to develop robust endpoints for clinical trials and clinical use. And also we're going to hear from Jochen Klenk, who is a professor of health sciences and head of department at the IB University, you'll have to explain what that is, for health and social sciences, and a senior researcher at RMBPF, the Robert Bosch Medical Foundation, yeah, at Stuttgart, and also he's in the Institute of Epidemiology and Medical Biometry at the Ulm University. He's a medical engineer and epidemiologist by background, and has done a lot of work on healthy aging, focusing on physical activity and falls risk. He's also working in sensor-based assessments and longitudinal data. And finally, Luca Palmerini, we're going to hear from you as well, I think, Luca, yeah. An adjunct professor in biomedical engineering at the University of Bologna. He teaches around the laboratory of wearables and mobile health for the master's degree in biomedical engineering, and his main research interests are in machine learning, signal processing from wearable sensors to predict various different events. And he's currently involved in a number of different large-scale European projects. So over to Clemens, first of all. Welcome. Thank you for coming to visit us.
Thank you so much. Hello, everyone in the room. It's really a pleasure to be here. And hopefully over the next couple of years, there will be some other occasions to come. So there's an ERC led by Sally and her team. And we had a very interesting day yesterday and today. So I think, yeah, here we are. So what I would like to do and introduce also my colleagues, as Sally has said, I was leading the clinical validation work. This is a huge project in about like 19 sites across Europe, many different countries. Sometimes, of course, we ran into huge problems because we collected a lot of the data during the pandemic. And we would like to present, let's say, some of the preliminary finding, but also some of the difficulties that we encountered, maybe also some of the errors we made. This is a huge project, so the funding by the European Commission was like 50 million euros. And what is very, very good news for those of you who are interested, 2 days ago, we made the technical validation data fully, let's say, accessible to everyone. So the technical validation study is now, let's say, open to be used for all of those of you who are interested, and of course also globally speaking. And let's say the clinical data will be released probably next year, but you will get some insight. But also we want to talk not only about the achievements, and a lot, let's say, of this work will be published over the next 12 months or so from the different cohorts, but also, let's say, over the different cohorts that you will see. And so I think this was really a journey that I very much enjoyed. So the key aims of this project that was funded within the so-called IMI, let's say, funding scheme. We also had quite a few partners from the UK, for instance, Lynn Rochester and other people, was that we're interested how to replace poor or possibly incomplete clinical endpoints. Of course, a big question in many European countries is that very often people from, for instance, rural areas are excluded, let's say, from data, but also, let's say, sometimes from some clinical services. So, and thirdly, of course, we did this in very close interactions with PPIE's patient involvement and engagement. This work was led by Alison Keogh and other people from Dublin. And of course, we were interested in increasing the measurement accuracy. And one of the main achievements, I think, is that we now can accurately measure also spatial parameters, such as speed in real world environments, and for instance, stride length and step. And one thing that partly we missed, we'll come back to that, was that we were in close interaction and are in close interaction with the regulatory authorities, such as the EMA and the FDA. but we'll come back to that. And for instance, some of the industrial partners did not, let's say, actually give adequate access to some of the data. So this is still, I would say, a missing piece. So in principle, let's say in this field, what we were interested in is that we, of course, we're interested on the willingness of people, let's say, to work with us. I'll come back to that. We're interested in predictive capacity, construct validity, whether we could characterize, for instance, different people from different patient groups according to their severity, as an example. And of course, we were interested if we can demonstrate meaningful change over time. So for instance, people with Parkinson's disease, multiple sclerosis, and other conditions would either deteriorate. And in one cohort, we were also looking for the recovery. We'll come back to that. Again, yeah, okay. So let's say the starting point was that a lot of us were looking in the past on macro parameters such as volume, pattern, and pace. I'll come back to the definitions. We were looking also at some of the micro parameters such as, for instance, cadence, variability, and asymmetry. And of course, we were not capable, let's say, of achieving everything, but overall, the technical validation study and the clinical validation study that a lot of these parameters can be addressed and measured at an accuracy level that, let's say, maybe 4 or 5 years ago was, I would say, unthinkable. A very big point in this context is the definition, let's say, of course, that you have to choose. And for instance, one question is, what is a step? So if currently you're looking at some studies that have looked at cumulated step counts, very often the accuracy of step detection is very poor. So what you have to think about is that a kilogram or a meter, this is something where you can drive to Paris and see what it is. In step counts, what you will often find is that an Apple definition or a Fitbit definition or actigraph differs. So what we have seen, and we want to come back to that point, is that if you compare a lot of these studies in meta-analysis, the numbers do not fit. So this is super crucial that you define and make it technically and clinically transparent. How do you define a step? In this, we used the definition of 2 strides. And from that on, we defined, let's say, walking as a pattern period. Basically, we looked at this project for 4 different cohorts. In the technical validation, we also had one cohort looking for congestive heart failure. So we looked at very different conditions: COPD, MS, PD, and hip fractures, proximal femoral fractures. And in subgroups, we also looked at sarcopenia and frailty. And this, of course, is a challenge because a lot of the MS patients might be in their 40s or 50s, whereas, for instance, a lot of the hip fracture patients might be in their 80s or 90s. So the primary endpoints in terms of predictions are listed here. So we looked at falls, care home admission, exacerbations, and mortality. And of course, we looked for a lot of other secondary outcomes that I will not go into. Of course, the protocol is published. It was quite a challenge to come up with a consented protocol that would reflect the needs of these different cohorts. And let's say if you plan such a study, this is super crucial that you have enough time. And of course, also these patients. So for instance, hip fracture patients, you cannot analyze for 4 or 6 hours. So we also had to make some compromises. So basically, this is the menu that we have technically validated. So we are capable of looking at what we call volume parameters, pattern parameters, including different, let's say, pace parameters. We have rhythm parameters and variability parameters. In terms of the feasibility, we can report that either if you use a body fixed or a body worn sensor, we let people choose to some extent what sensors they would prefer, a belt worn or a body fixed position, that overall more than 90% of the participants, let's say, were willing to accept it. So overall, we now have access to about 60,000 measurement days and more than 1 million measurements, measurement hours, let's say, reflecting these different features. So to give you a snapshot of what we can do, these are comparisons across the different cohorts. So we can measure what we call volume. Of course, that could be also cumulated walking time or cumulated walking distance. We'll come back to that in Jochen's talk. And we can look for different group, let's say, of diseases, but also, let's say, of severities. And for instance, then you can see that in different COPD classes or MS categories defined by EDSS and so on and so forth, that we can group these patients into different groups. Pattern, I think, is a very important way. So you can define pattern according to duration. So for instance, that would mean that longer duration of patterns, such as a walking pattern over 30 seconds, would reflect outdoor walking and so on and so forth. And again, you can see that there's a discrepancy between the different groups. And the third dimension, I think, you should take home. We think volume is essential, pace is essential, and pattern is essential. And then we have these subcategories that I've shown. And then we would recommend, for instance, to use walking pace for indoor and outdoor activities as a parameter, and that can be accurately measured with an error rate currently of about something like 0.05 meters per second. So that's a completely different dimension. Let's say if you would go back 3 or 4 years, most people would calculate but not measure the gait speed in real-world environments. And construct validity, we can say this is a subgroup analysis from the hip fracture group. And this is very important for remote monitoring. If you use digital outcomes for outpatients, it's possible that there's a good correlation, for instance, with things like the SPVB or the 4-meter gait speed or the tuck time. So that is clinically super useful that we can implement these measures also in outpatient settings, not only for trials, but also for clinical services. So some of the technical takeaways for trialists from our side is that we can implement this and they are technically robust and clinically valid. At this stage, if you want to use this for clinical studies, not for exploratory work, we would certainly recommend that you can start using volume, pace, and pattern. On all of this is open source and open science. And we think that it's now time that we can introduce some of these measures also into, for instance, clinical care pathways, and we can discuss that. Currently, at this stage, we would recommend that measures of variability and cadence are exploratory. We can, again, discuss this a little bit later, because let's say a lot of the work on these parameters or dimensions on construct validity, but also on outcomes, are to some extent need further research and insight into. So from my side, in terms of what possibly in terms of errors, but also maybe in terms of decisions we took need to be done in the near future, and some of these topics will be addressed today, is that when we planned the study, we discussed it, but we were not capable of, let's say, really having data of healthy controls living in the community. And this is now work ongoing. And Luca will present some work from Italy on this topic, because you need to frame it, let's say, not only for diseased conditions, but also, let's say, for healthy people living in the community. The second point, which is probably more important, is that based on a number of discussions and decisions, the Mobilise consortium so far has not produced reference values for sedentary time, uptime, and sit to stand. And again, Luca will come back to this. And this is definitely a deficit because this is something we need for the public health discussion, but also, let's say, for these conditions. And the third point, and this was a complete failure by our industrial partners, is the lack of data of randomized trials. So a lot of people, let's say at our department, other places have at least now started to collect data in non-pharmaceutical trials and pharmaceutical trials. And the EMA and the FDA clearly said to us that they will only start this discussion seriously if we come up with data from randomized trials, because in a sense, that's their world. And a big topic also is to making these data understandable. So lay people and clinical experts understand the data, because they cannot have a menu of 25 different parameters. So they need to understand it. So there's a very interesting paper now in progress led by our colleagues from Newcastle and Alison from Dublin that hopefully make a big contribution to make these data understandable. And again, we need to reduce the information and not come up, let's say, with a long list of parameters. So I think this is more or less what I have to say, and I will now hand over to Jochen. Thank you so far, and we'll come back to a joint discussion at the end. Slides.
Okay, yeah, good afternoon. I will now talk a little bit more about the analysis and the interpretation of the data. This is the slide Clemens already showed, and I want to highlight some aspects. In Mobilise, we had several assessment time points. This is the data from time point 1, which means this is not one time point. It's actually a period of 1 year where we access the data. And in COPD, MS, and PD, their conditions are quite stable in this period, but in PFF, these are patients directly after the hip fracture surgery. We have a lot of change within this period. So that's make this cohort also quite interesting to look at how mobility is changing. So here you see the number of walking bouts at T1 for this PFF cohort. And because we have so many changes, we decided to separate this period also in different phases. So we defined acute phase to 14 days, then a post-acute phase to roughly 6 weeks, and extended recovery and long-term recovery, half a year and the full year. And here you can see the first box plots here in gray, how this number of bouts increased during a recovery of after hip fracture. So this is a clear pattern how I would also expect that. I also want to highlight an important aspect when you analyze physical activity data, that we often use types of aggregation of the data. And this is what you see here as well. You see some aggregations here. This means that it's walking bouts beyond 10 seconds or larger than 10 seconds, walking bouts of 10 to 30 seconds, more than 30 seconds, and more than 60 seconds. And this is also important. Maybe you've seen this before, that some of the parameters we extracted from the data are related to a certain amount of time you have. Let's say a gait speed was validated, or the best validation was beyond 10 seconds. So we decided to have gait speed at 10 seconds. So this is fair enough. But if you consider PFF patients and people after surgery, you have the problem that maybe some people don't have these long periods. So you have missing data. And if you increase the length of the period, you see here, I posted here the number of missings. If you go for 60 seconds, you have 74% of people having no 60-second periods in all of the bouts. So this is, I think, also a very important point when we talk about very ill people, that some people don't have these long periods. Coming back to the steps, Clemens already mentioned that the definition, when we do research, we always want to compare different studies and see if we are comparable with others. But in steps, it's really an issue, because any device, any study is defining their own definition of what is a step, what do we count. In our case, we had a definition of strides, 2 strides as the bout length that we need, at least need to be counted here. In other studies, we have just 1 step. So the number of steps you get here, also from your devices you're using for step counting, it's really a difference when you compare these studies. So it's not easy to really say, okay, 10,000 steps in Mobilise is the same like 10,000 steps in another study. I think it's also very important when we compare studies and do the interpretation. Here you see that this progression of step counting during recovery, and we also try to do some new types of visualization on the data, and we came up with this quantile regression methods, which we think is quite useful also for clinical purposes, to model this progression and extract quartiles of these mobility parameters like steps. And what you get at the end is something like you might know from BMI values for children, that you have across this time period several curves, percentiles, as a cross-sectional visualization, where a clinician, for example, can look at what quartile the specific patient is, if it's above the 50 percentile or below, and yeah, see if the progression is like expected or if you can maybe improve it. So that's I like this presentation very much from a clinical perspective. It's much more realistic, I think, like calculating a mean value, for example, because mean doesn't mean anything clinical. It's just the average, but here you can really assign a person to a certain quartile. But you can also see that here I plotted also the different trajectories of our participants across the first 3 assessments we had from them. And you also see that there are also crossings across the percentiles for some people. Some follow the same percentile, but some cross it as well. And this is another diagram we are using to show if people remain in the same quartile or if they change. And for example, you see that if you're in the upper or lower quartile, there's a high chance that you remain in this quartile. So there's not so much change here. It's like close to 80% remain in this pattern, but in the middle there's a lot of change. So, and the question for intervention would now be, can we bring someone up from here to one of the upper quartiles or not? Yeah, and finally, another aspect we came up in the study is what is the correct volume measure you want to present to clinicians, but also to patients. And I just presented steps. This is a very common way to present volume, but other studies also use a walking duration. We also extract walking duration as a measure, but maybe for a patient, it's more interesting to get the walking distance to see what range of motion you have or what life space you have. And with the Mobilise algorithms, we can extract step length and also gait speed and extract something like a estimated distance that you can also interpret. So this is here just an example for the first 120 days where we try to estimate a walking distance that people have experienced after the hip fracture. And this might be more interesting for the patients to see, can I walk to the shop or to the whatever I want to go? Yeah. And maybe another aspect that also for comparison of studies, if you report walking distance, it might be a completely different story to walking duration. Because if you walk slow, it could be completely different if you walk fast. If you compare a couple, for example, walking to the same direction and a smaller person, larger person, they might have the same walking duration, but a completely different number of steps to get there, for example. And yeah, like Luca, for example, yeah. And if you interpret this kind of data, it's very important, I think, to also consider this and also always to ask what I'm interested in and what is the best measure to get the most out of the data. So okay, so that was my part.
Thank you.
Change the presentation.
Can we put off some notes? Okay. They are on the same. So. Okay, so I just go forward. Okay. Yep. Okay, so I will add to this, talking about how to extend what we saw with the Mobilise to community dwelling healthy older adults, as Clemens was saying, and to a more comprehensive picture of mobility. So Clemens already talked about this. So community dwelling older adults were underrepresented. There's a need for reference data on healthy older adults to understand the pathological patterns. And on the other hand, specific aspects were not yet considered, like how sedentary active the person is,
or what's its comprehensive view of mobility, not only walking. So it was good that Mobilise also aimed at Mobilise work also aimed to extend the analysis on external datasets, previous and future datasets. We did some work on standardization, so to make datasets comparable, especially previous datasets, but also future ones. And there is, as open access, the whole pipeline that can process data from a single sensor on the lower back, given that that sensor has certain characteristics that makes it compatible. So the idea was to use these, and so to use the same Mobilise pipeline on a study that we already had. So it was the InChianti study, is a population-based study of aging, collecting people over 65. It is a very huge study in the Chianti region of Tuscany in Italy, where red wine is very good, by the way. And so, I mean, it's a huge study funded also by the NIH, but we focus on the last follow-ups, where we had the possibility, thanks to the Foreseen project, where also Clemens and Jochen worked, to add to the clinical data that was currently available, also on a subset of people, some sensors. So a subset of people from the last two follow-ups use a smartphone, a Galaxy S2, so we're talking about some years ago, on the lower back with a belt. It had all the technical characteristics that we need to be Mobilise compatible, so accelerometer and gyroscope at 100 Hz sampling frequency, with an app working in background to record the data, and we also recorded prospective falls and other clinical information. So it's good because then we can extend, we can use the Mobilise pipeline and to exploit these previously collected dataset, which I think is a very strong point of the outputs of Mobilise. So on 200 participants with an average age of 80 years old and with 31 out of 200 prospective followers, we applied the Mobilise pipeline, and we extracted the digital mobility outcome that Clemens presented to you. So here just some representative examples. So the average walking duration per day, and you see now here we have reference data from healthy adults that can be used as reference for the pathological condition to know what the baseline is. The number of steps, what is the distribution? You can see a slightly higher number of steps than the pathological conditions that were shown before, and number of turns. Then we have pattern parameters, so the number of walking bouts, so continuous periods of walking, and the number of walking bouts divided by their duration, as Jochen was saying before. Then we also have pace parameters, like walking speed in a shorter and longer section of walking, but also parameters such as the maximum walking speed. And we can see here a walking speed of around 0.7 in shorter walking bout, and walking speed around 0.9 meters per second in longer walking bout. So these are all reference data that can be very useful. Then about rhythm, we have cadence in also divided by different walking bouts. Then we have the variability across walking bout, and we can have some reference data also for these. We can start looking at some relation to age. So this population-based study was mostly about aging. And so we see, for example, that walking speed was also able to correlate with age, as we expect. So a reduction in walking speed for increasing age. But we also can do something even more interesting. So the relation to prospective for risk for 12 months, people had a diary that they had to fill in. So in this, we did a comparison between non-fallers and fallers. And we see that we have some of the parameters were significantly different between the two groups. Some of them were significant in an exploratory way, some of them even if corrected for multiple comparisons, because as they were saying, we have 25 DMOs. If we do an analysis, we should also correct for 25 multiple comparisons. That means that the difference must be very strong for you to find something significant. But we saw, for example, that cadence was significantly different, being it higher in non-fallers, and also the maximum cadence had the same pattern. So this is about walking. So interesting results, some significant difference between fallers and non-fallers. Not all the digital mobility outcomes were significantly different, but there's something more to real-world mobility as was anticipated. So sedentary and active patterns, other movements and transitions. So for example, sit to stand, turns and standing balance. So what we did, so first we extended Mobilise-D to healthy adults. Here we extend the pipeline to other movements. So sit to stand, we use an algorithm that was validated in the real world, and we use an algorithm to extract parameters like the duration of sit to stand, the peak of the acceleration, the smoothness, and the displacement. And we then applied it to the in-Chianti dataset, and we saw two interesting things. The first one is that since we also had sit to stand from the laboratory assessment, the real world exhibited the different patterns with respect to laboratory. So for example, the duration is much longer for sit to stand, but also that there was no significant difference in the laboratory between fallers and non-fallers, but we had it in the real world, okay? And this also happened for other measures such as peak acceleration when standing up. Then about turns, immobilized only the outcome number of turns, so a volume outcome was analyzed. But there are other potentially interesting DMOs regarding turns. For example, we can evaluate the turns per hour, but also the turn angle and the smoothness during a turn. And we can see some exploratory work where we see that the prospective fallers and non-fallers had different values of these parameters. Then the more exploratory one is about standing balance in the real world, okay? So the idea is to try to do the standing balance test, the one that you do the Romberg test or the one you do on the first platform in the real world. So we had to do an algorithm that could detect a stationary, gait, turn, all transitions. And then with the state machine algorithms, we evaluated stationary periods between gait and sitting transfers, okay? We validated also this to be very specific, even if less sensitive, so that all the events of stationary standing, we were very sure that they were indeed standing. And what we did also here, we add the values in the laboratory, so you see the differences between the laboratory with a very small sway area and in the real world, where obviously the complex adaptability kicks in. And here we saw also the relation for risk, and in the real world, there was a longer duration, lower distance, and higher mean frequency that were predictive of falls. So as a conclusion, it was feasible to extract Mobilise-D digital mobility outcome in a community dwelling cohort recorded before Mobilise-D. So I think that is very, very important. We show the distribution of this digital mobility outcome in an older, healthy community dwelling population that can serve as baseline and comparison for pathological conditions. Some walking parameters were significantly related to prospective for risk, but we saw that also sit-to-stand, turning, and balance parameters in the real world provided insightful information on the mobility of a person and were related to for risk. As some limitation to keep in mind, I don't know why the font here increased so much, but the population analyzed had a relatively low fall rate, so they were 65 plus. We were expecting a fall rate a little bit higher. We only had 15%, so probably these people are a fit population, and the small sample size. We have 200 subjects, which is not bad, but it could be better. As future steps, we want to increase the sample size, to increase the analyzed mobility pattern, and also include the clinical outcomes and develop models for risk prediction. Part of these things, we will do it in the DARE project, an Italian research project on digital prevention. And just very briefly, I can show you the setup of some 2 studies that we will do. We will use the same sensor of Mobilise-D, but we will add the sensor on the wrist to add some more mobility, to add the sleep. And we will follow around 1,000 people, half frail and half older adults. And for 1 week, so with the same protocol of Mobilise-D. And then the aim is to develop a model for risk estimation that surpasses available models that use only clinical data. And we will do the same things. So this first one is on frail people and older people recruited by the hospital. Then we will try also something about 200 people with just general population recruited through the university. And in this, we will also add a more modern risk-based system that would also give us heart rate, and we will see if putting that in the mix will give us something about for risk. Okay, thank you. And for this part, I would like to thank this PhD student.
I was going to see if there's any questions online.
Yep. Or in the room.
Yeah, it's not in the room.
Yeah, comments or questions, please.
There's none online yet.
No, got it.
I think there's one coming.
Yes, please.
For each of your data collection periods, how long you collect for? It may be different from.
Yes, for these cohorts, we recorded basically 9 days, but we used the days 2 to 8 to analyze the data. In terms of stability of the data, we would say that you need at least 72 hours, sorry. And in these cohorts, we actually found, we were a bit surprised that the data on weekends were not so different from weekdays. So if you plan, we would still recommend to record 7 days. And because like the first day, the people will come to your lab maybe or something, the first day is quite different from the second day. So we would use this recording period. In terms of the sensor, there's not so many systems out there. The system we used for the body fixed position at L5 was the exhibity sensor from, let's say it's a company in Newcastle, and the cost is about 250 euros or something in this range. But you need accelerometers and gyroscopes. This is super relevant. No, the GPS question, for these populations, you would have to record. No, the problem is the battery life.
Yeah.
So as soon as you use GPS, you're down to less than a day. So for these populations, we said they will not be able to recharge. It might be different. And like the smartphone population in Chianti was somewhat different. The Welt-born device was a Dutch device. The problem is with the new, let's say, series that they produced, they're not quite sure if they can actually measure 7 days. So it sounds a bit funny, but currently we would only recommend activity for a 7-day period to be safe on the recording side.
Maybe one comment regarding the algorithm. The algorithm itself is device agnostic. So if you have certain parameters like 100 Hertz and gyro and accelerometer, you can just apply it on any device you have and you're using. So it's not limited to activity or MacRobots.
Just to add, the Python pipeline is in principle available for free for everyone. However, we have not performed a full cross-validation with the original software. So we expect that probably sometime early next year, we will have a cross-validation of the MATLAB-based algorithm with the Python pipeline. So there's a time window of a couple of months that we will need to perform that because there might be some discrepancies with the Python pipeline, but then this will be free of cost available for everyone.
So,
Many of us have opportunities to collect data. Thank you. Many of us have opportunities to collect data. For you, the next steps, what are the most useful opportunities that you can see that would help to build this work forward? I saw the bit on randomized controlled trials, but is that specific types of trials? Is it trials of medicines? Is it trials of what? Or is it something else that would help the consortium move forward?
As the follow-up structure, we have now 2 years of funding, which is called the sustain period of Mobilise-D. And for you living in the UK, the best person to talk to would be the team of Lynn Rochester from Newcastle. And their, let's say, their computer science department, along with a second group of Brian Coalfield in Dublin, is organizing the sustainability strategy. So I would recommend that you connect to them and talk with them if you have a community-based sample or an intervention trial. That's the one side of it. Then, of course, with the Python pipeline, many people will start to do that on their own, and that's fine. The third option, which I think is heavily needed, and we're talking to friends from Luca in Bologna, is to have a software solution that you can run on your own machines. So I hope this can be finished by next year, that, let's say, not everything needs to be coordinated within the consortium. So Lynn Rochester for the UK or Brian Coalfield at UCD in Dublin would be the people to talk to. Yes, please.
If you looked at any data from big biobank projects, I think the UK biobank, I might be wrong, but I think they have some data from wearable devices.
Yeah.
Is that compatible with your algorithms, or is that more?
It's the best I know. I'll hand over in a second. The UK Biobank currently has activity 3. So they have information on accelerometry, but they don't have data on gyroscopes. So that means that there are some constraints. Nevertheless, this is super valuable data, and there's data coming out from, let's say, Stephen Lord's group has used that data in a recent publication. There's a couple of things, let's say, under revision, but unfortunately, a lot of the huge data sets that we have globally have accelerometry data, but not gyroscopic data. So there's some constraints basically in spatial parameters. On gate volume, gate pattern to some extent, you can work with the data, but in spatial parameters such as pace and distance, there are some big constraints.
And also UK Biobank has the accelerometer on the wrist. So still there is some, I mean, in Mobilise consortium, there was some study to apply the Mobilise pipeline to the wrist, and the results were not that bad, but obviously you need also the gyroscope on the wrist. So, I mean,
That's one of them, that's to have possible.
lower back. So lower back. So Mobilise pipeline, you can have the best result that you can have if you put a sensor on the lower back. It has accelerometer and gyroscope with 100 Hertz. That's
just going to the cadence and the falls, you kind of had significance when you were looking at less than 10 seconds and then maximum cadence, but it wasn't when you were looking at 30 seconds or more. So where do you work out the maximums? Because you usually got to have, it could be an instantaneous maximum that's somewhat tricky. That's not a great maximum to take. So I was just wondering, is it like the maximum during a single bout length of 30 seconds or?
So it's the maximum in the walking bout. So
Is that got to be more than 10 seconds?
so
If the cadence is in about 10 seconds or more, or if it could be a shorter period also.
let me check that. So this one that was sensitive to
Yeah, sorry, I just missed it.
yeah. So this was in longer.
Yeah.
So only considering longer than 30. And in those ones, you take the maximum for each one and then you aggregate.
Okay.
A little bit broader than mine. I think that the terminology of maximum is not optimal because it's the 90th percentile. And this also goes for the other parameters. So Jochen and we are not happy with the semantics because sometimes, for instance, pace, if you cross a street, we're not so much interested in the 90th percentile, but we're interested if people in a certain condition can speed up and then be fast enough to cross the street. So there will be some debates of what is maximum, and we think 90th percentile is not maximum. So this is just, let's say, to keep in the back of the mind. The other point is that cadence, maybe we have a different opinion on that, but I think cadence for me is preliminary. So for instance, if you take Parkinson's patients as a group, they tend to have a relatively high cadence. So they have, let's say, smaller steps and a high cadence. So the cadence is somewhat, I would say, exploratory, how that can be applied across different conditions. So I think the data on volume, the data on pattern, the data on pace are quite robust, and we have the understanding on construct validity across the diseases, disease severity, and so on and so forth. Everything of Mobilise-D on variability and rhythm cadence is somewhat exploratory. So I put this in a sense as an interrogation mark.
Yeah, here we just run them all 25 DMOs of the menu, and I mean, cadence was the best one, but you see when you correct for multiple comparison, you're very near the limits of significance. So probably for full risk, in this population, yeah, the walk-in digital mobility outcomes were not super good, but yeah, so this should be tested again.
I think there was a question
Yeah,
in the chat.
You need to be Q&A or
Yeah, go ahead.
I can just.
Yeah, you can say it.
Give it a mic.
Yep.
So the remote people can hear it.
Thank you.
High cadence.
They've asked, was there a minimum detectable cadence for these analyses? Often steps recorded at very slow rates are detected poorly by wearable sensors and misclassified as standing. Differences in walking speed, so due to different clinical pathologies between groups, often contributes to between group differences. Estimates of stepping volume. Would be great to hear how you approach this.
Do you like to comment from the chat?
Yes, so I have to go by memory, so I'm not sure I
can start.
yeah.
This is a big topic. If you look at, for instance, things like the Apple Watch or Fitbit, steps, let's say, below a threshold of 0.4 or 0.5 meters per second are not detected. So, and a lot of the household activities, for instance, particularly from women, are at a relatively low speed. So this information is not captured. We've done this in the technical validation, and actually the step detection in, let's say, slow walking was quite good. So we saw that walking episodes of things like 0.3 and 0.2 meters per second were detected within the Mobilise-D algorithm. So in terms of sensitivity, we are quite, let's say, even with, we had quite a number of people with walking aids, like a rollator or a stick, and we could detect these steps. So we think this is a major, let's say, step we have taken in the detection of slow walking episodes. For instance, in terms of metabolic, let's say, energy consumption, this is very important. For instance, we see very often that men over-report physical activity and women under-report physical activity. And in a lot of the cardiovascular studies, for instance, this is not being considered. So this is really, I would say, one of the major breakthroughs that we have made in terms of detection, including, let's say, slower walking. So we're very confident on that. There are some constraints. So I can give you an extreme example. We have measured people 3 days or 2 days after a hip operation. And we see that if someone almost takes full weight bearing, then sometimes these extreme episodes are not detected adequately. But let's say the algorithms are now much better, but let's say I would not recommend to use it very early on a second or third day after, let's say, an operation of the lower extremity. That would be the extremes that we would not recommend.
Got any more questions?
Yes, please.
Just for a sort of patient rather than data point of view,
Just for the remote, please.
Do you have many problems with sort of when patients needed to wash them getting the devices back on, and do you miss much data because of that at all?
Well, that's why I would strongly recommend using the activity sensor. The way we have attached it, the people can have a shower, they can wash. The problem with the belt-worn devices, as you've said, is that people that go to a toilet might kind of like flip it or might not put it on again. So the adherence was more than 90% of the people when we used activity sensors. So I'm not saying this is good for 365 days a year, but most of the people were super relaxed of wearing it for 1 week. We did not have any serious skin irritation or anything, even though we had a lot of people that, for instance, COPD were having steroid medications. So we are very confident if you fix it properly that this can be done without any major problems.
Okay, well, 5 o'clock beckons, and I'm just going to take the opportunity to say 2 sets of thank yous. First of all, can I just ask you all to say thank you very much to our speakers, Clemens, Jochen and Luca. Thank you so much for coming all the way to Exeter to both chat to us about the Stepping Out project and the great work that we've been doing on that piece of work, and also for your seminar, which we've enjoyed immensely. So we're looking forward to continuing to work with you over the next few years, and just say thank you. So our audience. And then I'd also like to say thank you very much to Sophie, Claire, the BRC team, who have arranged the seminar for us, made sure we've got a great room, connected us with people online, organised the coffee, got all of the invitation out to everybody. So thank you very much, Sophie. Thank you, Claire. Thank you, BRC. And yeah, if anybody wants to come and say hi to any of our great speakers, please do come. They're all very friendly. They were last time I spoke to them anyway. And I'm sure they'd like to meet you, but thank you very much for coming. Thank you.
Thank you.
And share the slide with people.
Yeah.
I can send it in. I'll send it to one.
I think we've got the recording. We're going to share the recordings on the BRC website. We certainly are. Slides, if we want to.
We do have them on the desktop, so
Yeah,
we can
okay.
quickly put
No,
them
that's
on
fine.
OneDrive.
Yeah, we'll
Thank you.
Yeah, brilliant.
We need an article or.
Yes.
Was also